Bismillahirrahmanirrahim. Thank you, dear Professor Dr. Amr Husseini. Good day, everyone, and welcome to the introductory meeting for CRRT crash course taking place on November 18th and 19th. I'm Dr. Mahmoud Sheikh, nephrology consultant, CCN board member, and educator with World Kidney Academy. In our next workshop, we will bridge the gap between ICU and nephrology units, exploring how to prescribe CRRT safely and to optimize therapy to manage also complications and troubleshooting real case scenarios. It's designed to help every clinician, whether working beside in the ICU or managing therapy from the nephrology service, to feel confident and precise in applying CRRT principles. During this introductory webinar, we will also go through 5 clinical case scenarios, each one focusing on a key area of CRRT practice from prescription strategies and anticoagulation to effluent dosing, circuit troubleshooting, and filter performance. These questions set the stage for what we will discuss in depth during the upcoming workshop, where we will expand on each topic using interactive cases and evidence-based reasoning. So stay tuned, take notes, and get ready. Together, we are going to master CRRT practice. Starting with case 1, optimizing filter life in CVHDF, we have a 70-80 kilogram man on CVHDF who is experiencing recurrent filter clotting every 6 to 8 hours. Let's look at his current prescription. His blood flow rate is 150 millimeters per minute. His effluent flow is 2 liters per hour. His dialysate is 500 millimeters per hour. Replacement fluid is 1.5 liters per hour, all given post-filter. Now moving to the clinical goals, what this patient really needs. He needs strong control of urea and potassium level, and to prevent filter clotting, particularly from heme concentration, and also needs a liver dose of approximately 22 to 25 millimeters per kilogram per hour. So the main challenge here is to balance adequate clearance with filter longevity, especially given his repeated clotting episodes. Now let's test the logic, which change best meets all 3 goals he needs. Option A says keep the same split, just raise the total dose of 3500 millimeters per hour. That might look like more clearance, but it doesn't fix heme concentration, and high doses haven't shown survival benefit according to the studies. Option B, shift to a dialysate heavy split, for example, 1500 millimeters per hour of dialysate and 500 millimeters per hour of replacement. Okay, this improves small solid diffusion, but again, it doesn't address the main issue of hemoconcentration and circuit reclotting. Option C, keep the same total split, but move most of the replacement fluid to the pre-filter side. Okay, this one directly tackles heme concentration and lower filtration fraction and prolonged filter life while maintaining the same overall dose. Option D, switch to scuff. That's pure UF, no clearance, so definitely not meeting all 3 goals. And option E, reduce the blood flow to 100 millimeters per minute. That would actually worsen heme concentration and raise filtration fraction more. So the best answer here is to keep the split but move most replacement fluid to pre-filter. Let's talk about when to favor each approach in CRRT. This is the practical rule of thumb we use at the bedside. Choose pre-dilution when clotting is a recurring problem, when a hematocrit or blood viscosity is high, or when anticoagulation needs to be minimized. Pre-dilution lowers filtration fraction and usually prolongs filter life. That's why it's favored in circuit with frequent clotting or limited anticoagulation options. On the other hand, choose post-dilution when you need the best small solid convective clearance, and you can safely control heme concentration with adequate blood flow, citrate or heparin anticoagulation, and careful monitoring of filtration fraction. Of note that many centers actually run a mixed CVVHDF setup, combining some pre and post replacement fluids to balance solid clearance with circuit longevity. No matter which approach you use, the key here is to keep tracking your filtration fraction, TMP, trends, and the delivered versus prescribed dose. because that's what defines real performance, not just the numbers you see on the machine. Let's look at the pre-dilution solution and why it's often the right choice when we are dealing with recurrent circuit clotting. The pre-dilution effect lowers hematocrit and blood viscosity right at the same membrane surface. By diluting the blood before it enters the filter, we reduce sludging and maintain smoother flow through the fibers. This leads to a reduced filtration fraction, meaning less heme concentration and lower risk of clotting within the circuit. As a result, we get prolonged filter life, maintaining dose delivery and uptime, especially when the blood flow is kept at or above 150 millimeters per minute. Here is a key insight: pre-dilution does slightly dilute solid clearance, so you lose a little clearance efficiency, but at the same total effluent dose, you can maintain stable therapy and much better uptime. In other words, it directly solves the heme concentration problem that causes premature filter clotting. The question: why do the other options fail? Option B boasts diffusion for small solids but doesn't fix the heme concentration issue. Option A wastes solutions and still clots because the underlying mechanics haven't changed. And remember, very high effluent doses don't improve survival according to the KDIGO guidelines. Option D and E fall short on solid goals and may even worsen clotting, especially if blood flow is low, since that increases the filtration fraction. So pre-dilution isn't just a technical trick, it's just strategic adjustment that keep your circuit alive, your dose consistent, and your therapy efficient. Let's move to the case 2, ultrafiltration in cardiogenic shock using CRRT. This is a 72-year-old man presenting with cardiogenic shock and ERDS. He is severely fluid overloaded with a positive fluid balance of more than 9 liters. His current venous pressure is 18 millimeters of mercury, indicating significant venous congestion. Lactate is elevated at 3.8 millimoles per liter, suggesting ongoing tissue hypoperfusion and injury. His, he is currently on dual vasopressor support, norepinephrine at 0.28 micrograms per kilogram per minute, and dobutamine as 7.5 micrograms per kilogram per minute. Hemodynamically, his MAP is between 60 and 64 millimeters of mercury, heart rate around 18, and urine output only 0.2 millimeters per kilogram per hour. Lung ultrasound shows diffuse B lines consistent with pulmonary congestion. Altogether, this case represents the classic scenario of cardiogenic shock with fluid overload, where controlled UF becomes a key strategy to relieve venous congestion while maintaining perfusion. Now let's decide on the best initial UF plan for this patient in cardiogenic shock. Option A suggests starting 300 millimeters per hour net UF immediately. Okay, that's aggressive and unsafe in a hemodynamically unstable patient. Option B, 0 UF for 6 hours. This might protect perfusion temporarily, but it doesn't address the ongoing volume overload or pulmonary congestion. Option C, 50 to 100 millimeter per hour with hourly hemodynamic reevaluation. This represents a cautious physiology guided approach. It allows gradual decongestion while continuously assessing the patient response. And option D, stop all IV fluids and use dialysis only. This ignores the hemodynamic instability and risk further hypoperfusion. And option E, fluctuating UF from 0 to 500 millimeters per hour based on momentary mean arterial pressure. This introduces instability and can cause repeated shifts in venous return and perfusion. So option C is the correct one. Start slow and around 50 to 100 millimeters per hour and reassess frequently. Remember, in cardiogenic shock, UF is not about speed, it's about control and continuous monitoring. Now let's highlight the gentle ultrafiltration strategy, the winning approach for patients with cardiogenic shock or those requiring vasopressor support. Step 1, Start conservative, begin with slow and steady rate around 50 to 100 millimeters per hour, which translates to roughly 1 to 1.5 millimeters per kilogram per hour. Step 2, monitor hemodynamic and reassess hemodynamics every hour using point-of-care ultrasound, evaluating IVC diameters, B lines, and perfusion markers to judge tolerance and guide adjustment. Step 3, titrate carefully, gradually increase the UF rates only as tolerated based on real-time clinical response and stability of mean arterial pressure. The evidence-based practice is clear in patients on vasopressors. A gentle and dynamic guided UF strategy prevent hypotension while still correcting fluid overload. Let's quickly recap the pitfalls. Option A, starting with 300 millimeters per hour, as we mentioned, this is too aggressive and risk hypotension. Option B and D, either stopping UF or stopping IV fluid under treat the overload or prolonged congestion. Option E, fluctuating from 0 to 500 millimeters per hour, causing large hemodynamic swing that destabilize MAP. So the winning formula, as we mentioned, is simple: start slow, monitor hemodynamically, titrate with caution, and protect the perfusion while decongest. Moving to case 3 in CRRT and liver failure, this is a complex patient, 58-year-old man with septic shock and moderate liver failure, now developing stage 3 AKI. He is currently on vasopressor support, norepinephrine at zero point 0.2 mic per kilogram per minute, and vasopressin at zero point zero 0.03 units per minute. Looking at liver function, his bilirubin is 6.2 milligram per deciliter, and his INR is 2.1, indicating impaired hepatic clearance. For his vitals, heart rate is 112, MAP 64, and oxygen saturation 96% on room air. So overall, he's a hemodynamically unstable patient with multi-organ dysfunction, where managing CRRT in the context of liver failure requires careful adjustment of anticoagulation strategy and calcium balance monitoring. The question now, which buffer choice is best? Option A, bicarbonate 32 to 35 millimole per liter. Option B, lactate 40 millimole per liter per hour per liter. C, no buffer at all, 0. D, scuff without dialysate. E, high acetate solution. And the correct answer is A, bicarbonate 32 to 35 millimole per liter. Let's move to one of the most important buffer choices in CRRT, bicarbonate. The clear winner here in patients with liver failure or high lactate metabolism of lactate is impaired, which increase the risk of worsening metabolic acidosis if lactate-based solutions are used. Bicarbonate, on the other hand, is the preferred buffer for correcting metabolic acidosis during CRRT, especially in liver cell failure, because it restores pH balance independently of hepatic metabolism. Now, look at this matrix. On the vertical axis, we have safety, and on the horizontal axis, we have efficacy. In the optimal zone, you see bicarbonate-based solution at concentration around 32 to 35 millimoles per liter. They are both safe and effective, providing reliable acid-base correction without hemodynamic compromise. On the upper right, lactate buffers can appear effective, but in liver failure they are unsafe because impaired clearance leads to vasodilation and hemodynamic instability more and more. In lower zones, acetate buffers are unstable and can cause severe hypotension, while low buffer system simply leaves acidosis uncorrected. So, in the clinical takeaway here is lactate-based solution may worsen lactic acidosis. No buffer leaves acidosis uncorrected, and remember, scuff removes fluid only, not acid. For acid-based control in CRRT, bicarbonate is the clear and safest winner in liver cell failure. Moving to case 4, rising venous pressure in CRRT, we have a 58-year-old trauma patient on CVV HDF using right femoral access. Over time, the venous return pressure has been steadily increasing from plus 250 millimeter of mercury up to plus 320, while the arterial pressure remains stable at minus 120 millimeters of mercury. Both effluent and replacement flows are stable, meaning there are no major circuit or flow issue elsewhere. So the question becomes, what is the most probable explanation for this isolated rise in venous pressure? Let's review the answer choices for this scenario. Option A, venous limb kink or thrombus at the catheter tip. Okay, that would cause an outflow obstruction and lead to a rise in venous pressure. Definitely something to keep in mind. Option 2, filter clotting. This usually raises both pre-filter and post-filter pressures, not just the venous pressure. Option 3, air trap, partial obstruction that tend to cause intermittent or erratic pressure changes rather than a steady rise. Option 4, mechanic transducer error. That's a mechanical issue, not a true physiological rise in pressure, and often resolved after checking or recalibrating the transducer. And lastly, option 5, hypovolemia, and that would lower pressures, not raise them. So keep this in mind as we analyze which mechanism best fits the pressure pattern seen in this case. And the correct answer here is venous limb kink or thrombus. Let's break down the reasoning. Selective rise in return line pressure always points toward an outflow obstruction. That could mean a catheter tip thrombus or kink in the line, or sometimes even a vessel spasm. Simply repositioning or straightening the line often corrects the pressure and confirms the diagnosis. Now let's look at the why other options doesn't fit. As we mentioned, filter clotting would raise post pre and post filter pressures, not just the venous one. Air trap or transducer error cause erratic, not steadily increasing pressure, and hypovolemia would actually lower pressure, not raise them. So the key teaching point here is simple but crucial. When you see isolated venous pressure elevation, think outflow problem, usually at the catheter site. Moving to a last case, case 5, severely hypocalcemia in CRRT. We have a 68-year-old man on CRRT using regional citrate anticoagulation. He developed a new hypotension and tetany, clear signs of acute hypocalcemia. His calcium infusion is running at 80 millimeters per hour of 10% calcium gluconate. Now let's look at his labs. His systemic ionized calcium is 0.7 millimoles per liter. That's critically low, and his total calcium is 2 millimoles per liter, which is still within the normal range. And his post-filter ionized calcium is 0.25 millimoles per liter, which is right on target. Finally, ECG shows a prolonged QT interval consistent with severe hypocalcemia. So the key here is normal post-filter calcium, but critically low systemic calcium. This will guide us towards the right diagnosis in the next slide. Now, the question is, what's the most likely cause of his severe systemic hypocalcemia? Let's look at the option carefully. Option A, citrate accumulation from liver failure. That would cause both high total to ionized calcium ratio and metabolic acidosis. But that's not what we are seeing here. Option B, calcium infusion line disconnection or precipitation. That could definitely lead to a drop in systemic calcium while post-filter calcium stays normal. Keep this one in mind. Option C, excessive citrate dose that would lower both systemic and post-filter ionized calcium, which doesn't match our data here. Option D, inadequately dialyzed flow removing citrate that would actually raise citrate levels and alter post-filter calcium, again not consistent here. Option E, low magnesium causing secondary hypocalcemia, possible but it doesn't explain the acute and isolated drop in systemic calcium with normal post-filter levels. So we will need to decide which option best fits the pattern. We will reveal that in the next slide. Let's look at the correct answer, calcium infusion failure. This happens when calcium infusion line is either disconnected or there is precipitation inside the line. Here is the key diagnostic clue. When your post-filter ionized calcium is normal, but your systemic ionized calcium is critically low, that tells you filtrate removal is fine. The problem isn't with citrate, it is a failure to replace calcium. That failure is usually due to kinked or disconnected calcium infusion line. So in this case, the post-filter ionized calcium is normal, around 0.25, but the systemic ionized calcium is critically low, about 0.7. That pattern confirms a calcium infusion problem, not citrate toxicity. Let's look at why the other option doesn't fit the scenario again. First, citrate accumulation like liver failure that would raise total to ionized calcium ratio above 2.5 and cause metabolic acidosis, and this is not what we are seeing in this case. Next, excess citrate dosing. If that were the case, both systemic and post-filter ionized calcium would drop. But in our patients, the post-filter value is perfectly normal, so that doesn't add up either. Then there is an adequate dialysis flow. If the dialysis flow were too low, citrate levels would climb, which would push the post-filter calcium out of target. Again, not happening here. Finally, low magnesium in it can coexist, yes, but it doesn't explain the acute change when the post-filter calcium is normal. So here is the clinical picture. If your post-filter ionized calcium is normal, but the systemic ionized calcium is low, that's point to calcium replacement problem, not a citrate accumulation. Thank you all for attending. We are looking forward to seeing every one of you at our next CRRT workshop. Stay connected with us and follow our YouTube channels for more updates and sessions. Thank you. Goodbye.